Well, thank you very much, Deirdre. I think the plan is I'm going to go first and probably talk for somewhere around 35, 40 minutes or somewhere around there. We'll have some questions, and then I think Karly's going to come in after that. This whole lecture, as Deirdre mentioned, is going to be recorded, so it will be available, but I've also given her a PDF version, so she will be able to share the PDF version, which will have the links in it. And there are one or two links I think you'll find quite useful in there to take forward and read further. It's always very hard trying to get everything from a lecture when you're in there. And my idea is to really fill your heads as much as I can with lots of concepts and ideas. I'm not here to try and sort out the cure for your individual headache, each one of you. I'm really trying to paint a picture as to the broader sort of picture of migraine as a whole condition and as a whole way of being, so that you recognize yourself. And if you can recognize yourself and you can actually see the way things fit together, then you'll be in an advantageous situation compared to your doctors or other people that might be treating you. And you can take snippets of this to your doctors or other people treating you to try and actually improve your management, obviously doing the things you can do first. So I apologize if some of this is a bit complex. I apologize if I haven't explained exactly how migraine occurs, but then we don't really understand it fully anyway. So I'm going more on the stories that you guys have given me over the years, which is how I've built up most of this from what patients have told me, and then putting it together with what the literature shows, but most of it's from patients. So more than just a headache. And it's not going to do that, so I'm going to So these are my clinical disclosures. That's a bit boring, but it shows all the people that I give advice to. I've got a couple of other disclosures on the screen. That's decaffeinated coffee, and just in case it runs on a long time, that's actually decaffeinated Coke. So when I pulled the ring tab before, it wasn't a Guinness, sorry, and it didn't have caffeine in it. So I'm going to talk a bit about the scope of the problem with headache. I'm going to try and compare and contrast migraine with some of the other primary headache disorders. I did, as Deirdre commented on, I have done a talk to Migraine Association Ireland about cluster headache not long ago, and that talk is available as well. So those wanting to look at that, there'll be some features on cluster headache in there that they can look at in more detail. I'm going to try and talk about episodic migraine, in other words, episodes of migraine, but I'm going to then try and put it into the context of how that becomes chronic. We don't use the word chronic to mean it's really bad, which is what the lay public use it for. We use it to mean that it's giving you more than 15 days a month of headache, and more than 8 of those are severe. I'm going to try and portray the relevance of the non-headache features to diagnosis and management, because they have quite a lot of relevance. So why is headache important? So I write my lectures for clinicians and for patients. I don't actually change them. I try and give the same lectures to both, because I think doctors need to know about things from the patient's perspective and vice versa. So when I do these slides, they're partly for doctors as well. So, you know, why is headache important? The doctors want to know that you haven't got a life-threatening disease, and you, even more importantly, want to know that. They're really rare things. That's the needle in the haystack compared to the vast numbers of people out there who have got chronic headache disorders. So in other words, when you see a doctor, they're going to be wanting to try and exclude the brain tumor or the something else. But actually, the vast majority of you here will have a benign condition, in the sense that it's not going to kill you, but it will be a potentially highly disabling disorder. It will cause you to lose time for your families, for work, for other people. So there's a huge discrepancy between the really rare things that doctors are trying to exclude, but the huge disability out there that often gets left on the shelf once the scan is normal. I also wanted to, I will sort of briefly talk in this lecture about sort of other illnesses and other conditions. And quite commonly, migraine can be misdiagnosed as a stroke or a TIA, a mini stroke, or multiple sclerosis, or sinusitis, or depression, or fibromyalgia, or stress, or anxiety. So it's a common cause of misdiagnosed illness, and without a diagnosis, you don't get a treatment. So it's really important to get the right diagnosis. Any one of you here that's sitting with and has had headaches for more than 4 months, you can be fairly reassured that you probably haven't got a brain tumor, because you wouldn't be here. People with brain tumors and nasty things causing headaches, typically they'll present within weeks of that, and they will have other focal neurological problems that you will recognize. They're arm or leg will go weak and stay weak, or they'll lose their speech, or something will happen that stays there. We will examine them, find a finding, and we'll get them in and find the problem. So just by the fact you're all sitting here, and most of you will have had headaches for a long time, you can sit back and relax and not think this is something worrying. When I said sit back and relax, sorry to put up a picture of Anthony Hopkins on the screen there in a rather sinister pose, but I couldn't find a picture of the really nice Dr. Anthony Hopkins, who worked at the London Hospital and in 1989 did a third national morbidity survey. And he was actually a superb clinician, no relation to this Anthony Hopkins as far as I'm aware, but it's a nice slide. But he showed that nearly 10% of the population consults their GP each year for neurological symptoms. Now, this is an old slide. Do you remember the days when we had GPs and you could go and see them and you could consult them about things? Things have changed a bit in the last few years, and the health system is cracking under the strain. But migraine is by far the commonest cause of anyone seeing their GP, is what I'm saying. And if we look at the World Health Organization, they've looked at what's above the radar. They've looked at people presenting with headache as migraine. And you'll see from the rest of this talk that most of it's directed to people who don't actually have headache. So what's above the radar is people recognized to have migraine. It's one of the 3 most prevalent worldwide conditions, next to anemia and hearing loss. 324 million people affected worldwide. The World Health Organization rather considers it one of the 4 most disabling conditions, equal to quadriplegia, psychosis, and dementia in the disability that it causes. And if there are any women sitting out there between the age of 16 and 50, then migraine is thought to be the most disabling condition known to womankind between those ages, and it's in the top 3 for men. It's going to affect people at the most important and busy times of their life, particularly people between the ages of sort of 18 and 50, 55. And it's going to cause school absence in kids, and often it will be unrecognized. So this is called a Union Jack, and I apologize. I'm not trying to be inflationary here by putting that picture up. I just only realized just a second ago that I was about to put a Union Jack up to an Irish audience. But in the UK, 25 million days are lost each year to migraine, either from work or school. Most people are solely reliant on OTC or over-the-counter medications, the paracetamols and Nurophens, and 2/3 want better treatment. So that's the UK. And if you start looking elsewhere around other countries, it's very similar pictures. So we've talked about what's above the radar. What's actually below the radar? What actually happens when migraine hasn't actually been recognized and it hasn't been diagnosed? So misdiagnosis rates for migraine are reported to be as high. This is large studies. As many as 60 to 80 out of 100 people who go with headache disorders to their GP or another specialist will be misdiagnosed. Now, it's usually that it's migraine and someone's been diagnosed as not having migraine, like, for instance, sinusitis or neck pain or cervical spondylosis or vertigo or Meniere's disease or something else. So most people, it's not that migraine is diagnosed as something else, it's that what they presented with wasn't correctly diagnosed with migraine, because migraine is by far the most common headache disorder out there that we see. So there will be a few musical connotations here and slides. So this is Madness, the band. So what did we and what do we still consider to be psychiatric? Now I've got this book. Unfortunately, I haven't got it behind me at the moment. I should have got it out. Virtue's Household Physician. It's from right at the back of the 20th century. And it was contributed to by really famous people. William Gowers, one of the most famous neurologists that's ever existed. Charles Darner, Savary Pierce, they're all the names of the day. And they put on hypochondria as hypochondria. The skin will twitch in different parts or feel numb or have the sensation of spiders crawling on it. Now, I bet you if I asked you out there how many people get the feeling of tingling or little bits of your body twitching, I would guess at least 60 to 80% of you have that at some time. And then they were also talking about, this is again, is hypochondria they're talking about, it's not migraine. So bright sparks are seen before the eyes. At one time, the person will feel as large as a barrel, at other times not larger than a whipstock, which is the handle of a whip. The head will feel light or heavy, large or small. The smell becomes perverted. The hypochondriac will smell odours where there are none. The persons are subject to fainting turns. They are irritable, fretful, peevish and fickle. Now, we don't tend to judge our patients as much as they used to in the old days, but most of that you'll see in this lecture, and many of you will notice these things. So bright sparks, we're talking about aura. The large as a barrel or very small is Alice in Wonderland syndrome, the main cause of that being migraine. I'll come back to that. The head will feel light or heavy, you're all aware of that, lightheaded or heaviness of the head. It may feel large or small, that's the Alice in Wonderland syndrome. Smell becomes perverted, that's the osmophobia, similar to photophobia and phonophobia, that becomes amplified. Fainting turns, migraine syncope. I think migraine is the commonest cause of fainting out there. Yet if you go to any website, or so any clinical service that does a fainting clinic, they only recognize cardiac syncope, vasovagal syncope due to a drop in blood pressure, or epilepsy. And that's pretty much the only 3 types of blackout they recognize. In my clinics, I see migraine to cause maybe 60, 70% of everything that I see with fainting or blackouts. So important concepts about migraine. It's a significant, it's a reversible, and it's a relatively invisible cause of disability. It's much more than just a headache. Migraine it represents the amplification system for turning normal bodily sensations into symptoms. And the more I've looked at patients with this, the more I've realized that most people, the sort of symptoms they describe would have previously been described as neurotic. Now they're described as functional neurological symptoms. But what they're talking about is migraine and the amplifying normal sensations into symptoms. Some patients may present with headaches, most people do, but it may present with many symptoms, but yet little or no headache. It's easily overlooked, it's easily misdiagnosed, it's kept going by inappropriate treatments, especially overuse of painkillers and caffeine. And we specifically need reliable, specific and effective treatments that target all the symptoms. And we are getting there with that. So who actually treats headache and who needs educating? So most patients treat themselves. So patients really need educating. And you'll have lots of different sources to go to, some of which are reliable, many of which are on forums, which have a potential to be highly unreliable because there's a huge bias in forums. The person who's had one bad effect from something which may not have even been the drug, it may have been just a placebo-related effect, but they will want to tell everyone how bad that thing is. Even a GP recently turned around to me, to a patient of mine, and said, "You don't want to try these CGRP monoclonal antibodies. They're really poorly tolerated and they're very dangerous," which is the complete opposite of every single bit of research that's ever been done on them and all the clinical experience from those people using them. And I bet that GP has never even seen a patient who's taking them. So you've just got to be careful who you listen to. I'm not saying don't listen to GPs, but take things with a pinch of salt. We've got pharmacists, we've got opticians will see you because you've got headaches and you think it's your eyes. Relatives will lend you their tablets. You might go to a GP, but you see the font is getting smaller. The chance of seeing a physician or even a neurologist or even a headache specialist is getting pretty remote. And this wasn't a slide made for Ireland. This was a slide made for the UK. So it's bad here. It may be worse in Ireland, but it's bad here as well. So what do we need to teach and what needs to be taught? We need to recognize the rare and dangerous causes of headache versus the reassuring features. We want to know that patients with headache disorders may not actually present with headache. They may not complain of headache. They may present with dizziness, fatigue, irritable bowel syndrome, fibromyalgia type symptoms, other pain, lots of things. Headache may be relatively low down their list, but unless it's on the top of your list, no one's going to think of headache. They'll start going down a rabbit hole of other problems. We need to recognize it's a cause of relatively invisible yet severe disability. And most important, which is why you're here tonight, we want to empower optimal self-management, because unfortunately, you need to get your right treatment, because unless you do that, many people are not going to get it, and you need to actually know where to fight and how to fight. So this is an old picture of the headache, but is your headache migraine or something else? So some red flags, just so you're aware of it. But I want you to, before we go through the red flags and you all think, oh my God, I need to leave this lecture and go and see my doctor now or go to casualty, note the bottom 2 points. Serious disorders don't generally take days off. So if you're worried about brain tumors or anything nasty inside the skull, and you have the occasional day, even if it's only once every 2 or 3 months where you feel normal, that's not going to be what happens in a brain tumor or something nasty. Nasty things don't take days off. And the other thing is, we often get asked to see people, the GP will write saying, can you see this person? They've had a headache now for 18 months and they're getting really worried as it's going on so long. We have the opposite way of seeing it. I think it's very hard in primary care when you see someone who's only had a headache for 3 or 4 weeks because it hasn't really declared its features or its overall spots yet. It's much, much easier when someone's gone on for more than 4 months and nothing nasty's happened to them. We know we're likely to be dealing with a primary headache disorder. There's a colleague and friend of mine called Giles Elrington who he basically has done scans on everyone in his private practice over years, and he's presented data showing that less than 1 in 1,000 people who have had headaches for more than 4 months turn out to have something nasty on their scan that's actually causing their headache. Less than 1 in 1,000 of people with headaches for more than 4 months. So that's a really useful stat to take away. But if, on the other hand, you've got a new daily headache which started and never left you, and it's less than 4 to 6 months, see someone, only 1 or 2% of you would have a significant underlying cause. And I know this because I've investigated so many people over so many years. That's the figure that we all find. If you had a first and worst headache, if you were doing something and suddenly you had a sudden thwack to the head that made you really unwell and you were vomiting and you were drowsy, you're going to go to casualty. So that's a thunderclap headache. Anyone who has headache not exacerbated by, but actually specifically brought on when you stoop or poop, that's the medical terminology, sorry if it's a bit complex, but coughing, sneezing or straining, stoop or poop headaches, we want to rule out any structural problem at the back of the brain called Arnold-Chiari malformation, where it's just it's developed wrong and you get some outflow from the spinal fluid being a bit blocked. And we want to, if it's only a recent headache that's brought on by those things specifically, we want to scan you. Headache that's always worse when flat and is always alleviated by standing, it alerts us to things. These things don't stand alone, but we look for other features when you have them and then come to a decision whether it's nasty or not. But headache, beware, that doesn't mean that it's tended to lie on a certain part of your head. It means that the actual lying flat bit, rather than the sitting up or the standing, it gets better the more upright you are. It's not about the pressure on your head. If you're over 70 and you've never had headaches and you get new headaches, we worry a bit more. There is a condition called giant cell arteritis, which is very rare below the age of 65, but it makes you systemically very unwell. You lose your appetite, you lose weight. You have severe tenderness just around the artery on the side here, and that artery becomes very hard and craggy. And every time you chew, it's like normal food. It's like a really bad steak, and it makes you start getting jaw ache. Well, normal food starts giving you jaw ache, jaw claudication, and you're really tender over the top of your shoulders and top of your arms and top of your legs. We look for giant cell arteritis. That's an urgent one to GP, but it doesn't really happen below the age of 60 or 65. Anyone who's got regular daily headaches, and they're also losing weight, they've got fever, they've got neck stiffness, or they've got cancer or HIV, clearly you want to go and see someone. But I'm going to concentrate on non-serious headaches. So what types do we see? In the textbooks, it would say there's a thing called tension type headache, but actually, I don't think that really exists, and many of my colleagues also don't think that exists. Tension type headache is generally a milder form of migraine. And I could give you a whole separate lecture on does tension type headache exists. Deirdre's making notes there. So if you want, does tension type headache exist? I'll give you that lecture on another day. Migraine, by far the commonest. Then you've got hemicrania continua, then cluster headache, then new daily persistent headache. And then you're coming into rare things, which I'll come down to later. That bottom bit on the bottom of the screen, I thought it said tension type headache, but it was actually just a smudge, I think, was tension type headache doesn't exist. So the most important discriminating questions that we look for in a headache clinic, and these are things that when you're going to see your GP, you might want to actually think about and give them the answers, give them 2 sentences on each of these, because then it'll tell them that you know what you're looking at. What's your behavior? Do you want to lie down and be still in an attack like a wounded lamb? Or are you restless and agitated like a wounded lion? You can't stay still, you're holding your head, you're rocking, you're absolutely restless and agitated. That's really important. It very much differentiates between migraine and cluster headache. Is it side locked? Is it just on one side of the head? Has it only ever been on one side of the head? Again, that makes us think of things like cluster headache. How long do the attacks last? When do they occur? Are there particular times of day that happen? Does alcohol trigger these the next day, or does it trigger it while actually drinking that first glass of drink? Are there specific things that bring on pain, like touching, cold wind, chewing, eating, talking? And then we start thinking of neuropathic pain disorders like trigeminal neuralgia. There's another condition called SUNCT, which is in my lecture a bit later. Do you have prominent cranial autonomic disturbance? Red eye, runny eye, droopy eye, puffy eye, twitchy eye, stuffy nose, runny nose, fullness in the ear, tinnitus, flushing, sweating? Because although those things all happen in migraine, they're much worse and they're much more prominent in conditions like cluster headache. And finally, do you get bouts, bad headaches for a few months at a time or a few weeks, then it completely disappears, and then it comes back the next year at the same time? Again, we're thinking of cluster headache. You notice on that I'm not really looking at all the things that you will have ever been asked by a doctor. Most doctors ask you all the things at the bottom. Do you get sensitivity to noise or light or smell? Do you have nausea? Do you have vomiting? Do you get visual disturbance? Now, those, yeah, they're all features of migraine, but they're also features of everything else that we're going to talk about. So they absolutely don't discriminate. They don't help me in one way know what your headache disorder is. But as doctors, we seem to think we ought to put those down on a piece of paper and ask you about them. And we don't ask you the really important things, which is the top part of that slide. So hopefully you're all with me and you haven't all switched off. I'm just going to carry on going. I can see Deirdre occasionally nodding, so at least I know that I've not frozen. So the differential diagnosis of primary headache, I think this is a slide really to take away and digest, but I want to focus on tension type headache. Well, it doesn't really exist, so don't bother looking at that one. It's a bilateral headache that's never severe, that's never associated with any stimulus sensitivity to noise, light, or smell. It doesn't get worse when you move about. I've asked so many audiences in the past, even like medical students over the years. I've only found 2 people who I think may have had tension type headache in a 25-year career. Migraine, I'm going to talk about a lot in a minute, but it's a condition that makes you stay flat and still. Doesn't have much of that cranial autonomic disturbance, but they can be there. It can be unilateral or bilateral, more than 4 hours, to days, to weeks, to months. Hemicrania continua, a continuous headache on one side of the head, severe. Yes, you're going to get the sensitivity to noise, light, and smell. You're going to get prominent red eye, runny eye, twitchy eye, stuffy nose, runny nose. You're going to feel a bit agitated. Cluster headache, it's going to be attacks maybe 1 to 4 times a day, lasting between 20 minutes and 4 hours generally, but most last between 15 and 40 minutes. It's usually almost always side locked. It's normally incredibly severe. Women say it's far worse in childbirth. And you get very prominent autonomic disturbance, you get very prominent restlessness and agitation. People want to punch themselves in the head with this one. Paroxysmal hemicrania is identical to cluster, but you're going to get lots of attacks in the day, between 10 and 40 attacks. They're going to last 10 to 20 minutes. There's a rule on this, basically, for these conditions. These are the trigeminal autonomic catharsis: hemicrania, cluster, paroxysmal hemicrania, and SUNCT. So SUNCT stands for short-lived unilateral neuralgical headache with conjunctival injection and tearing. The longer the name, the more attacks you get, and the shorter the attacks will be. So by the time you get to SUNCT, this hugely long name, you're going to have 60 to 400 attacks a day, lasting for up to 2 minutes, usually around the temple or around the eye. Severe plus autonomic disturbance, and you're going to see a neurologist. You need to see a neurologist about that one because your GP won't know how to manage it. Unless you want to try GammaCore, obviously. And that's one of the reasons that you're here tonight, because you will hear how GammaCore can help in migraine, hemicrania, cluster, paroxysmal hemicrania, and SUNCT. Although Karly can't tell you that, she can only tell you it's helpful for migraine and cluster headache from the trial perspective, although there is data for hemicrania, and we've certainly seen anecdotal evidence for the other ones. So it's a tension type. I love this painting because this is Magritte, and it's a type band-like headache, except there's no head, so therefore there can't be any headache, therefore tension type headache doesn't exist. Right, that's proven. Cluster headache or migraine. I think this is a useful slide just for those of you that think you've got cluster headache, often diagnosed by GPs as cluster migraine because they can't make their mind up. There's no such thing as cluster migraine. It's like saying there's I don't know, a Ford Vantage. Well, you can't have Ford and Aston Martin. Well, actually, they're the same company. That's a bad example. But you know what I mean. So cluster headache, restless, severe, short attacks, alcohol triggers immediately, it's side locked. Then you'll notice that these things at the bottom, aura, flashing lights and zigzags, well, they're the same in each. I'm going to argue that aura doesn't belong to migraine. Aura is a separate phenomenon that's recruited by migraine in its attacks during parts of the cascade of migraine. And it can happen equally in any of the headache disorders I'm going to talk about. So I think that's a myth that aura is part of migraine. It's just another brain biology that's linked in and recruited by migraine. And all the sensitivities to noise and light, well, it's going to be the same. Right, so I'm not going to go through this cluster attack slide because it's partly what I've said already and it's on the side. I will just say though, at the end of this slide, these slides, I've put a whole appendix section. So do get the actual PDF of the slides, because there's going to be a whole load of extra information for you to look at on restless legs and on a lot of the other features of migraine. Hemicrania continua. I'm just going to say this was a picture in a migraine art book by Podol and Robinson, but it's not migraine. This is going to be hemicrania. The person thought they had migraine and the doctor probably thought it, but this is typical for hemicrania. Primary stabbing headaches on one side, side-locked headache to one side, pain around the eye, nose, and down the jaw and teeth, and a watery, droopy eye. It looks like this patient's had a stroke. If this patient has a constant daily headache down one side, it's hemicrania continua. That's what it looks like. I would argue that we see patients who are almost all on one side of headache, but it's not always just one side. I don't think indomethacin is a good drug. I've never had a patient that's been able to really stay on it without getting gastrointestinal bleeding and as their sole treatment. Nerve blocks, really, really effective in this condition. Injections at the back of the head or side of the head or front of the head, but also GammaCore. At least 50% of people respond really well to GammaCore. If I had hemicrania continua, I would start with GammaCore if I had no restrictions, and I would move on to nerve blocks. You know, it's likely to sort you out at least 50% of the time. So that's hemicrania continua. Unusual types of headache. So we've got alarm clock headache, or I've just forgotten the name of it. I haven't actually got dementia. Later on, we'll talk about memory problems. A lot of people will say, oh, I can't remember names, I can't remember words, can't remember why I went into the room. That's a classic example of migraine and other things that cause you to not think. That's hypnic headache, alarm clock headache. We have weightlifter's headache, or headache induced by exertion. There's headache induced by a primary headache associated with sexual activity. There was an interesting study there which showed that actually people who went on to a specific type of injection that we cannot prescribe, when their husband insisted they wanted to carry on, actually at least 50% of people found it was a very good acute treatment for their migraine. But obviously I can't allude to actual words before the 9 o'clock watershed zone. That's not a headache, that's exploding head syndrome. People that suddenly get a bang, waking them from sleep just as they're going off to sleep. Not a headache disorder, nothing serious, don't worry about it. It's just like the feeling of falling off a cliff when you're going off to sleep. Normally I ask the audience, does anyone ever get a sudden jolt as if they're falling off a cliff when they're just going to sleep? And I then say it's a stupid place to go to sleep, but I can't do that online. This was actually a guy who's the blade of the knife snapped off in his head. He went to casualty and he didn't realize he had a knife in his head, which was slightly crazy, really. I think he might have been wearing a hat and didn't take his hat off. But that's to illustrate primary stabbing headache, which is nothing to do with knives. A lot of people get a sudden jolt where they just feel a sudden stab in their head. And it's very common in all the primary headaches, particularly hemicrania continua, particularly migraine. So migraine is a systemic disorder. It's not just about the head, and it's a multi-symptomatic disorder. Do make a note of this link, because this is the comprehensive migraine guide that I've written. It's going to encompass most of what I'm talking about tonight. It will give you a very clear plan of what to do. This is endorsed by the NHS. I wrote it for the NHS Vanguard in the UK. It's within the Right Care, NHS Right Care pathway. So www.bit.ly/migraine booklet. I'll flash it up at the end. So that's me a few years ago with my son, who's now practicing with his band at the moment. But this is just show the genetic predisposition. We look almost identical. So migraine predisposition if you've had travel sickness, irritable bowel, Raynaud's, hangovers where you've only had a small amount of alcohol, or headaches triggered by your hormonal menstrual cycle, triggered by not too little or too much sleep, or too little or too much stress. If as a child you had episodes of tummy pain where you'd go very pale and have dark rings under your eyes and feel very, very washed out, or if you've got a family history, these are all features to suggest you have the genes for migraine. And migraine isn't just an attack, it's not just a headache, but it's a biology that you've signed up to by the way you're made. So you can get all those migraine features can happen just regardless of the cause of headache. You know, it could be a migraine that gives you all the migrainous features, but it could also be a subarachnoid hemorrhage or an episode of meningitis, or it could be cluster headache. All those things will give you migrainous features. So you don't have, if you've got a migraine biology, when you present with your headache, you're going to present with sensitivity to noise, sensitivity to light, sensitivity to smell, nausea or vomiting, and movement's going to make it worse. So that it just tells you that that's the way you're made. It doesn't tell you the diagnosis, which is why you sometimes need to go to the doctor if you have those red flag features. So the disorder versus the biology, I think it's a question of how many genes you have. Do you have lots of migraine genes or just a few? If you're male, you have less triggering by hormones, particularly before the age of 55. So males don't get as much of it as women, but afterwards we can catch up a bit. Does everyone have a tendency to migraine? I think they do. And if so, by how much? The presence of migrainous features does not mean it's migraine. Everyone with migraine may wear a migraine hat. In other words, if you've got the migraine biology, you put on your features of migraine, it's going to happen with anything. And patients with cluster headache and meningitis have aura, sensitivity to noise, light, smell, nausea, and vomiting. So the definition of migraine, it's a primary headache disorder characterized by central sensitization, which means that there's wind up in the brain, all your nerves are, all the nerve circuits are firing much more actively. But it's got neurological brain features, it's got systemic body features, and it's got autonomic features. Those are the nerves that control your automatic functions like your heart rate, your breathing, your digestion, your passing urine, your opening your bowels, your blood pressure, your sweating. So it's, in other words, a brain disorder with symptoms throughout the body. And there are three main things that happen in migraine: amplification, brain dysfunction, and autonomic disturbance. So amplification, what would normally be a sensation of just a feeling something's there, becomes pain. There's nothing changed about this skin here or this part of my skull. It's just that the brain has basically switched on those areas and amplified them and tells you it's pain. It will be tender, even light touch, like brushing your hair, can be exquisitely tender, allodynia. You're more likely to be sensitive to movement, noise, light, smell. But it's not just those senses, it's also your input from your ears. You've got your nerves coming in from your vestibular apparatus in your ears. And if that's slightly amplified and it's not quite equal, you're going to start feeling dizzy with your headaches. You've got all the autonomic features: nausea, vomiting, dizziness on standing up, including this condition of POTS, where you've got a fast heart rate. Often in people with postural, so people with sort of joint hypermobility who can bend their thumbs back and everything, they often get POTS. You get diarrhea, pass more urine, you go pale, your eyes go red, runny and droopy, your nose goes blocked and runny, your ear feels like it's underwater or on a plane with fullness, you get noises in the ears. I think you also see bruising and swelling. I've got patients with migraine who have come to me where they've had zigzags and flashy lights, they then go tired, they get no headache, they get painful swelling in their left leg, and as it gets better, it goes through all the colour phases of a normal bruise, and it happens reliably with their menstrual cycle. I've seen that on quite a few different patients. So you do see some weird and wonderful things that you wouldn't think about because they haven't told you about headache. Brain dysfunction, we see aura, the things I've just talked about, zigzags and flashy lights, we see numbness and tingling, we see speech disturbance, we see mood change, confusion, fatigue, and restless legs, all brain dysfunction. And this slide is a fairground strike it lucky with a hammer, but it's actually strike it unlucky. What we try and do is we look at the things that build up. You've got I can't necessarily change your hormones. Sometimes we can. We take away caffeine. We take away we try to avoid stressful times. We try to avoid alcohol, because all of these things may add up, and you hit the bell, you get the migraine. So with good lifestyle, we can get you further away from your triggering level, and then we can lock it in place with a preventative treatment. That's the way I see it. So the lifestyle is first and foremost. It's not just chucking a treatment in, It's getting all the lifestyle, so we actually get you as far away from your triggering level as possible, and then locking it in place with a preventative to try and stop it taking off. Episodes of migraine happen with a prodrome in up to 85% of people, whereas auras only in 20% of people. Then people go through a headache phase and then a postdromal phase. And I will come back to these in a second, but the postdromal phase, I don't think I'll come back to. So that's just feeling tired, tender, and a bit irritable. But this is the prodromal or premonitory features. So you can work out who's got yawning there, who's got, I mean, this is a bit UK centric, I'm afraid. There's despair and dysphoria, Theresa May there. There's anger and agitation. You all know who that guy is. And then there's hunger. So there's some nice person who decided on Brexit who basically is tucking into a sausage roll and not thinking he's being looked at. But all these things, fatigue, irritability, aggression, depressed mood, euphoria, hyperactivity, restlessness, feeling unreal, yawning, phonophobia, photophobia, osmophobia, feeling lightheaded, craving carbohydrates, thirst, dizziness, neck pain, neck stiffness, loss of appetite, frequently passing urine, diarrhea, restless legs. These may all be seen for hours or even 2 or 3 days before a migraine attack. Now, just imagine that you have craving of carbohydrate. So what's your favorite? Oh, I'll go and get some cheese. I'll go and get a cheese sandwich. Oh my God, every time I have a cheese sandwich, I get a headache. Why do you have the cheese sandwich? I don't know. Were you craving carbohydrate? Yes. Okay. So the cheese in the cheese sandwich did not trigger your headache. The headache was already there. There's been very good research to show with functional imaging that the hunger is associated with features of the migraine that are already there before you had your cheese sandwich. Why do you get headaches? Oh, it's when I'm tired and I haven't slept well. Well, actually, the not sleeping well and the tiredness is the premonitory phase of your migraine. So yes, if you've burned the candle at both ends and been out late all night, it might be you. But for many people, they haven't slept well because their migraine is there. Some people, it's, oh, when I get depressed or fed up. Actually, the depression and fed up bit is part of this. So you can see how these things fit in. And a lot of people think they're triggers are actually triggers, when actually in reality they're not triggers. They're just obeying what their brain's asking them to do. But their migraine has already started. So that's really important. That's just a really bad slide showing aura. Normally, you might get tingling that spreads up a limb, maybe to the face and maybe to the arm. But as it spreads, these bits, the hand should get better as it gets to the face. Or you may get visual disturbance with distortion and zigzags and flashy lights. Now, a lot of you will know what that's like. At least 20% of you know what that's like. So I'm not going to go through that. Sometimes it's a problem with speech where you can't get your words out. Pregnancy is notorious for giving bad aura. So first part or second part of pregnancy. And then the non-headache symptoms of acute migraine. I'm not going to read all of these out, but you can go back to these. They're very similar to the ones we talked about during the premonitory phase. And it can include coma. So, it can give you syncope, blackouts, it can give you coma, hallucinations, all sorts of things. Gastroparesis, it stops your stomach moving, you get vomiting. So people present with cyclical vomiting syndrome. But if you can look through those, there's loads of stuff in there that you will recognize. I'm not going to spend much time on Alice in Wonderland syndrome, but just to say that migraine is the commonest cause. It's distortions of reality. It can be things like an insect eye with lots and lots of visions, a bit like the Bohemian Rhapsody video of all the people there, top of the pops. There can be things going very big or very small. It can be the surroundings appearing completely wrong. It can be that your arm, when it's on the steering wheel, feels absolutely huge. It feels like that big compared to the rest of your body. It can be all these sorts of features. It can be halos around objects, things zooming in and out, a distortion of sense of time. And if we look at what was described, so Alice in Wonderland, you've got Alice who's much too big for the room or whatever, and a lot of it is very, very typical of migraine. I love this slide because it's got the name macrosomatoagnosia in, and I spent so long actually trying to pronounce it that I try and pronounce it with every lecture, just because it's such a long word and I can think I'm really clever. But this is a person with a huge head, a bigger head than mine. And that's basically in the book by Pearl and Robinson that I mentioned before, migraine. This is Alice in Wonderland's part of migraine. So I've talked about the autonomic symptoms. I'm not going to run through that. They occur in 20% of people with headache disorders, whether it's migraine or cluster headache. but you get other autonomic symptoms in the body, more passing of urine, diarrhea, dizziness on standing, etc. And there's just an example of a person. He's not trying to tell you to go away politely with his fingers. What we're actually seeing is a bit of redness of the eye, a bit of drooping, and a bit of puffiness of the eye. And that's very typical of the autonomic disturbance that we see in migraine or hemicrania continua. Now, don't just think that migraine causes pain in the head. It can cause pain anywhere in the body. And you, at the base of your brain, you've got the trigeminal system at the brain stem that sends signals to the thalamus, which is an amplifier for the brain. The trigeminal system receives inputs from the face, from the lining of the brain, the meninges, from the around the shoulders, from the upper back. So all these things are linked in. People get neck pain. About half the people with migraine will get neck pain before they get headache. The neck is not a problem in your neck causing headache. It's a problem that your brain doesn't know where things are coming from. And when the migraine turns on, it can localize pain to the neck, to the shoulders, or the head. So don't get stuck on the idea that neck problems are causing headache. Again, I think I've seen that truly happen in one patient in my whole career. I've seen thousands of patients who come to me being told, I'm told that it's a neck problem, and it's not. Everyone goes and gets a scan and says, I told you so, there's the discs in it, I've got degenerative discs, I've got spondylosis, my GP's diagnosed me, that's my problem. But I can take 100 people over the age of 25 off the streets, put 100 people in an X-ray machine or a scanner and find cervical spondylosis in 100 people. So it's not a useful test. So that whole idea of cervical spondylosis, if it's a disc in the neck, you're going to get a specific numbness that stays in your arm, or a weakness with a loss of reflexes. It's not going to cause this sort of problem. So there's pain in migraine. It can be anywhere. Legs, abdomen, face, head. I said this to the pain team when I was lecturing to them. I said, well, they said, oh, come on, this can't be true. And I said, well, what about migraine, abdominal migraine? Have you heard of that? Oh, yeah, no, well, we accept abdominal migraine. I said, well, why do you accept abdominal migraine, but none of these other places? And none of them could answer me. This is the home of the Pain Foundation in the UK. They couldn't answer me. And the reason is that this isn't in the body, the pain, it's in your brain. I've shown you that before. So when you go from episodic to chronic migraine, and this is the really important part of the lecture, because most people are only seeking help when it's becoming a more severe problem or a more pervasive problem. So chronic migraine, more than 15 days of the month, in other words, less than 15 days, absolutely crystal clear and headache-free. And I think the concept of crystal clear headache-free days is really important, because most people won't tell their GPs or their other people about the number of headache. They tell us about the bad headache days. What they don't do is tell us about the mild days. If someone complains of 2 headaches a month to me, but they've got background headache on every other day or 20 days a month, the treatment is totally different. So it's a chronic migraine is a headache which becomes more frequent, becomes more severe, becomes longer lasting. The gaps fill in with milder migrainous headaches. So instead of going from sea level, no headache, to snowdonia, a maximum headache, and back down to sea level again, episodic migraine, they change into the Derbyshire Dales. And they have an underlying undulating days of headache where it may be very mild, it may almost disappear, it may disappear at times, but it's often undulating. They don't have the peaks as much. So it's like a squashed in or compressed version of episodic migraine. And the painkillers stop becoming effective, and also the preventatives stop becoming effective, and they get pervasive non-headache features, which I've got in the next few slides. So you have an inherited predisposition, you're born with the genes, you have all these features like travel sickness, etc., irritable bowel, Raynaud's. Something comes along and triggers it, whether it's hormones, because you're a woman and at certain times of your life you'll have different hormonal triggers, or you have a neurological illness, or you develop COVID, or you have a flu or a head injury, and then it's perpetuated usually by painkillers, by triptans, and by caffeine. So the headache, it may have a mild background headache, there may be more severe migraine headaches lasting hours to days, stabbing headaches, occasionally it may be little or no headache. This slide is the one I really want you to go back to and think about when you look at this lecture, because this basically has most of the things on it for most people with chronic migraine. And interestingly, pretty much all of those things disappear when you get your crystal clear headache-free time or day, possibly with the exception of short-term memory and concentration difficulties, which may be more pervasive. But people have different types of dizziness. They go spaced out and detached with dissociation. A bad headache may make them vertiginous, where they feel like they're on a boat or moving. They may get visual vertigo where looking at certain sort of stripes or escalators, patterns on a shirt may make them dizzy. Going round to the right, it's common to see tingling, it's common to see twitching. The twitching that we see in the body is often periodic limb movements, which is part of restless legs, which I'll come back to. You may see panicky type symptoms, lump in the throat, difficulty swallowing. You may see syncope and blackouts. You may see the hallucinations of Aura or Alice in Wonderland, red eye, runny eye, droopy eye, puffy eye, twitchy eye, stuffy runny nose, fullness in the ear, tinnitus, flushing, sweating, or passing too much urine, or loose bowels. Memory problems, usually people can't remember words, they can't remember names, they get stuck halfway through sentences, they come out with the wrong words when they're talking, and they start putting their phone in the fridge. So that sort of memory problem isn't dementia. That sort of memory problem you see in migraine, you see in pain, you see in poor sleep. That's not dementia, okay? You may see low, irritable, oh, got someone drawing all over my slides, that's nice. But you may see low mood, irritable mood, emotional mood. You may see restless legs and periodic limb movements. It's very common to see other pains. Other people call it fibromyalgia. I call it migraine, because the other bodily pains are part of this overall central sensitization. It's all part of the same thing. Stiff, tight, tender, achy neck, like a coat hanger across the shoulders, fatigue and weakness. So that's what we see in migraine. And on the really crystal clear headache-free days, these things disappear. You lose your postnatal depression, your chronic fatigue syndrome, your fibromyalgia, your vertigo, your neck pain, when you're absolutely 100% crystal clear and headache-free. Maybe I'm being a bit optimistic with fibromyalgia. I think once you've got fibromyalgia, it's a bit like a plasma telly that's being left on. There's often an imprint of something there all the time. It's nothing in the way of medication is ever going to get rid of that. There's no point trying to go on gabapentin and pregabalin and painkillers for fibromyalgia. All they will do is make it worse in the long term. Fatigue, I'm not going to go through this slide. Restless legs, I'm just going to touch on this before I wrap up. So Thomas Willis described this in 1672. So wherefore to some, when a babe they betake themselves to sleep, present in the arms and legs, leapings and contractions of tendons, and so greater restlessness and tossing of their members ensue. I don't think he'd written it with that line, thinking what we think these days when we see that. But if the diseased are no more able to sleep than if they were in the place of greatest torture. So restless legs is really nasty. I recognised restless legs as part of migraine about 6-7 years before it was first ever in the literature. And I was going around lecturing around the country, around the world on it and treating people. So I recognise the presence of restless legs with migraine way before it was first in the literature. And it's something I've been quite passionate about treating. You can find restless legs by knowing that before you go to bed, particularly late towards the evening, you want to move your legs or arms, you want to stretch, you want to move. They're just irritable, there may be sensations in them. When you get up and walk around, it feels better temporarily. You go and sit down again, it's worse. It's worse towards the end of the day. It's worse when you're still. It's better with movement. You may wake up quite a few times at night. You may dream a few times at night. We're all dreaming a few times a night, 5 times a night. This is normal sleep. That's dreaming, REM sleep, 4 times a night. We all do it. When you've got restless legs, you do it more because you're waking up more. And whereas normal sleep sees us go into proper deep slow wave sleep, and then later on it's not quite as good. With restless legs, this is just a Fitbit device from the internet, someone's Fitbit. They're not going into deep sleep. They've only done it twice in the night, and they're getting a lot more light sleep, and they're waking. Every single red line is waking. So this person's woken about 25 times during that night. They think they've been asleep all night. Okay. So Fitbit's often quite useful. Restless legs, it's got exactly the same mechanisms as migraine. It's all about dopamine. Dopamine's the chemical for addiction. It's the chemical that makes you want to take more painkillers and take more caffeine. Dopamine is the chemical that makes people want to stay on medications for these things as well with restless legs. So if you stay on your restless legs medication too long, you'll start getting worse again. You get augmentation, and then it's a real nightmare. So you mustn't stay on treatment for more than 8 months for this. You can have a break and come back to it. But 60% of people don't need treatment. They stop their caffeine, they stop their painkillers, they stop their triptans, awful for a week or two, and then they're fine. Go to your GP to get blood tests on ferritin, B12 and folate, and look at these values in the slides that you'll get, because these are borderline, not low, but it's worth treating in that situation. but you stop painkillers and caffeine if you've still got restless legs, an 8-month course of very low dose pregabalin, up to 50 for a woman, up to 75 for a man, for 8 months, highly effective at restoring normal sleep architecture. It actually gives you back those proper deep slow wave cycles that you need. So that's restless legs. So these are all the people that diagnose migraine wrong. GPs, stress, anxiety, depression, sinusitis, spondylosis. Ophthalmologists say it's visual disturbance and glasses. Dentists say atypical facial pain and trigeminal neuralgia, but clearly facial pain can be part of migraine. We diagnose it wrong for blackouts and epilepsy, vertigo, dizziness, sinusitis, neck pain, chronic fatigue, pelvic pain, hyperemesis gravidarum in pregnancy, prominent vomiting throughout pregnancy. Psychiatrists think you're all depressed, anxious with panic disorder, conversion disorder, or psychosis. But actually, when I go and talk to psychiatrists about this, they recognize a lot of patients they've seen, they've not looked at them properly. So you see all these things, fibromyalgia, chronic pain, irritable bowel. But if we get it right, you can often sort all of this out. Sorry. Misdiagnosis leads to problems, including stigmatization. So red flags for chronic migraine rather than acute, your medications have become effective, you've got few crystal clear headache-free days, and you've got a list of symptoms. And for anyone that says, I can't stop painkillers, look at the Headhunt study from 2003. 51,000 patients studied. Basically, overuse of analgesics was the strongest predictor for who was going to get chronic pain 11 years later in those with headache disorder. And it's only now that the UK NICE guidelines have recognised we should not use painkillers, gabapentin or pregabalin for chronic pain. They're just recognising this. This study was 20 years ago. So I'm going to give you, in the slides, look at the BASH guidelines for how to treat episodic migraine. That's actually really helpful, that link. It will show you how to treat it. Look at the episodic migraine bit, it will tell you what dose of things to use. But I'm going to argue that if you have quite prominent migraine, episodic migraine, then try not to follow it with lots of painkillers. If the more headaches you get, the less you should use acute attack medications. You should consider stopping caffeine if you're getting migraine, however often you get it. Fluids, food, and sleep. So it's like building a house. You start with the foundations, no painkillers except rare emergencies, maybe 5 or 6 times a year. Now, this is chronic migraine. If you're just getting episodic migraine once or twice, 3 times a month, you might treat it. But if it's more often, if you're getting less than, say, 25 crystal clear headache-free days, I would recommend stopping painkillers, stopping triptans, stopping caffeine, loads of fluids, regular meals, regular sleep. So avoiding all these sort of triggers. If someone could try and stop using the mouse, I don't know if other people are seeing this and they're underlining things, but it's showing up on all the slides. So it's gradually lots of squiggles on it, which makes it a little bit harder for others to read. So chronic migraine is very treatable. 40% respond to good lifestyle. We treat the sleep disorder next with the restless legs. We treat with a preventative. After that, which one do we use first? I must admit, I'm a huge proponent of non-invasive stimulators because they do not cause side effects, they do not cause problems. They're often highly effective, both for the acute attacks and for prevention. And if you're not using painkillers, then these can be really useful at reducing your tendencies to chronic migraine. So I'm a huge advisor for, in my practice, for using non-invasive nerve stimulators early. But alternatively, you may go to your GP and get trials of some of these drugs, beta blockers or candesartan. Don't be put off if you have low blood pressure. They're fine. If you turn off the migraine, then you'll turn off the low blood pressure. The low blood pressure is often part of the migraine. If you're not winning with these other approaches, then you may be able to get Botox or a CGRP monoclonal antibody treatment, but they're more tricky. I have given my private link in the end of these slides, and I'm willing to do video consults with anyone from Ireland if they want. I can certainly prescribe GammaCore. I can prescribe, and I'm sure Karly will fill you in on how to get GammaCore anyway, but I can prescribe it. I can arrange for you to get Botox on the mainland in Liverpool. I can arrange for you to get nerve blocks. I can arrange for you to receive the CGRP monoclonal antibodies. So there's a lot that we can do. And also I can prescribe flunarizine, I think, relatively easily as well. So there's a number of things that we can do there for you. So regular drugs, take it for at least 12 months at the maximum tolerated dose, give each one at least 3 or 4 months to start working. If you get mood or memory problems, stop it. Start slow and stop slow. Commonest reasons for failure are still using lots of painkillers or caffeine, not getting to the right dose, not taking it for long enough, or you're taking it with side effects like sedation or mood disorder, and it's never going to work in that situation. So I'm not going to go through that. Basically, that's just a little bit of humour to try and wake you up before Karly comes on. I'm not going to go through the summary because I think I've said everything I need to say. But what I will do, hold on, all right. Come back 1 second. So my computer's just being a little bit slow. So this again is Virtue's household position. This is what they said in the 1920s about tea and coffee headaches. I think they got this right. In the nervous, now GPs might say mad. We don't like using that terminology in our patients because we actually recognize the disorder. We don't label our patients as having psychiatric disorders when they don't have psychiatric disorders. So in the nervous, translate gouty and rheumatic person to the person with fibromyalgia. The use of tea and coffee will cause violent headaches. These luxuries of life should be discontinued for at least 1 month. An extra strong cup of coffee, to be sure, will stop the headache for the time being. It's a painkiller, we know that. It only adds fuel to the fire in the long run. I couldn't say it better myself. We'd strongly advise anyone that has constant or periodical headaches if uses either tea or coffee, and especially coffee, 70 grams per cup versus 30 grams for an instant one, up to 250 grams if you're going really full Starbucks. So especially coffee, to leave them off entirely for 3 months, it may be the sole cause, 40%. And if caused by tea or coffee, there's no possibility they're cured by medicines while you continue their use. We cannot get people better with preventive treatments if they're still overusing acute attack painkillers or caffeine. And if you think you need the painkillers for fibromyalgia or another reason, stop it, because those other pain disorders will be no worse. Once you've done it, you'll need a few weeks to get used to it. If you're stopping opiates, do it more slowly. And I'm going to leave you with that, which is details for my remote video consultations. If you want to write those down during questions, is also the guidelines for the British Association of the Study of Headache. If you just put that in Google, you'll come up with that. And my comprehensive migraine guides at the top there. So I'm going to stop there, and I apologize that I've run over quite a bit, but hopefully that was worthwhile.
Okay, hello everybody. I will be 10-15 minutes or so, just in case you're trying to plan your dinner this evening and keep to Nick's well-advised regular patterns. But yeah, my name's Karly, and I do work for electroCore, who are the manufacturers of the device GammaCore that Nick has mentioned a couple of times. I've also just spotted a very well-timed question come into the chat. Thank you for that one. I did not plant it. But yeah, by trade, I'm a pharmacist, and I did spend 12 years in retail environments. And so I am very well aware of some patients who like to have a bit more of an understanding behind some of the treatments that they're receiving, rather than just being told to go take something and you'll be better, or use something, you'll be better. So I'm just going to give you a very, very quick light. I'm not going to give you a science lesson, I promise, because I don't know it, into an introduction to the vagus nerve and GammaCore device itself. So what is the vagus nerve? Well, as this slide suggests, and also termed there the wandering nerve, that's because any people that studied Latin out there will know that vagus also means wandering. But as you can see from the GammaCore man there, the vagus nerve starts in the brain cortex. It branches out to both left and right side, travels down through the body, reaching many organs on the way, and finally ends up in the gut. And so therefore, as you can see through the notes on the slide, it does play a big significant role in modulating many bodily systems. And as Nick mentioned, some of those autonomic functions that keep us alive and present without thinking about it. So the heart rate, breathing, your digestive system, etc., etc. So what we can do, you might have heard of two phrases, one being fight and flight and one being rest and relaxation. That's something that every normal body system will do within a 24-hour period, and you will flip between those depending on current state. So if there's a trigger or there's something alarming, you will go into the fight and flight, so you get the elevated heart rate, you get the increased breathing, the anxiety states kick in, and that's your body shifting its natural capabilities to defend off whatever's coming in. You also then have the rest and relaxation phase, which ordinarily will happen at nighttime through those sleeping times that Nick showed on his graph. And they're important for cell regeneration, and as it suggests, the body's restoring phase. So what we can do with GammaCore is that we promote the shift into the parasympathetic, which is the rest and relaxation. Now that could be that we're enhancing it to either interrupt neurotransmitter levels, inflammatory pathways, and body's metabolism, or it could be that people actually suffer from something that you might have heard being talked about called vagal insufficiency or poor vagal tone. And that's where people spend more of their time in the fight or flight zone than that rest and relaxation time. So, oh, my slides won't move on, sorry. There we go. Oh, no, I've gone too far now. There we go. So GammaCore, what is it? It's been mentioned a few times tonight. You may be familiar with it, you may not. I have one to show you. I'm going to do a demonstration on myself of how you actually use it. And there's some contact details as well about how you can obtain it. So to quickly answer that question, yes, it is available in Ireland. So GammaCore's full name is it's a non-invasive vagus nerve stimulation device. So what that means is that we're going to stimulate the vagus nerve by the point closest to which it reaches the skin surface, which is in the neck. And it's non-invasive, i.e. does not require surgery. It's something you use at home, and the predecessor of the device, not ours, was an implanted device that would sit under the left-hand side in the chest cavity. A wire was programmed and wrapped around the vagus nerve and stimulated every 5 minutes for 24 hours a day. Our current medical director and co-founder of GammaCore developed this device, and we have, many years later, 5 CE marks in Europe. We've got FDA approval, and it's recognised within NICE guidelines in the UK. Those 5 CE marks do include primary headache disorders. So that big table that Nick showed early on in his talk, we are licensed or indicated for use in all of those primary headache disorders. So primary headache disorders means a headache without any other cause. So not a headache related to a brain tumour. Excuse me. We've also are adopted in 20 countries, roughly, globally. So that we do have strong evidence portfolio behind it, and anyone that's really interested in that, I can happily direct and share you to that. But what we do through GammaCore, as I alluded to, is help restore, reset, and replenish that parasympathetic balance. So whilst you're having a look at that slide, I'm going to show you how easy this device is to use. So it's a rechargeable, by rechargeable, I mean battery and therapy. The battery life on it will last a couple of weeks. So it's not something like your new mobile phones that you have to recharge every few hours if it's as old as mine is. You use this electrode gel that comes with it. You place it on each electrode surface, and you place the device, I normally say, in the squidgy part of the neck. So you've got your throat at the front and a hard muscle at the back, and I'm going to place the device in that soft bit there. I'm now using buttons on the side just to increase, and I'm in a stimulation zone. All this is doing is sending electrical impulses through to stimulate my vagus nerve. Now, when I do eventually stop talking, you'll see a lip pull. Okay, if I take the device off, I'm just going to exaggerate that lip pull so you can see it. The lip pull goes away. So what if you're a user of GammaCore or decide to try it, then you remain in control of that therapy all the time. I otherwise describe the sensation as champagne bubbles on the neck. It doesn't hurt. Some people quite like it. And it's not pulling on any other muscles. As the slide suggests, it's very safe to use, very minimal side effects. They mostly relate to topical use, so the gel or the metal surfaces, because they do contain nickel and stainless steel, which some people might react to. We've got simple solutions for that. The evidence that we have suggests that people can experience pain relief in as little as 30 minutes. And the acceptable study standard is that pain relief is maintained until 2 hours, which we're also able to evidence. So a typical treatment regime, this is going to last for 2 minutes, so it'll go off automatically shortly. And I would do this twice as one treatment regime. For migraine sufferers, we normally advise as a preventative regime that you use it twice a day, so morning and evening. And you can also use it in between if you need to for acute use. Now we have, for those people that are out there and using GammaCore, you may have noticed a slight change in what I just said. We used to say 3 times a day, but we do have some evidence that suggests that twice a day is sufficient. But if you want to use it 3 times a day, more than happy that you do. So that's stopped. My lip pull's gone away. That would be one of my 2 stimulations. So basically a treatment period is 4 minutes in duration. Sorry, I'm just wiping the gel off my neck, otherwise I will look like I've got a peeling neck. So how do you get GammaCore? So it's not a prescription item, but it does, because of its clinical validity, we do ask for an authorization by a healthcare provider. So a healthcare provider could be your GP, it could be a neurologist, a specialist, it could be a pharmacist, a physio, a chiropractor, nutritionist even, just anybody within their competence to be able to authorize your use of GammaCore. There are very few people that can't use it. And if any healthcare provider has any concerns about authorizing use, email us. I will happily educate anybody about its appropriateness to be used. And this is the form. That's the only information that we require, is the patient details, the authorizer's details, and then which package is wanted. So you can see the prices down there. It isn't a cheap therapy, but if you are paying for alternatives, or you're having lost work days, you're missing out on social events because of your migraine suffering or other conditions, associated ailments, then that price might actually be of great value to you. We do have people that have been able to return to work because of their using GammaCore. And so, yeah, it's an individual choice and a balance, but I appreciate that cost is not achievable for everybody. The device itself comes in the starter kit, along with a therapy card and the gels, and the refill kits. You get more gels and the card. And the card is very simple. You load it against the device, a bit like accessing a hotel room, and it just transfers from the card onto the device, and that would be the 93 days course of therapy. For those who do respond well to GammaCore, and I will answer my own question there, what is the response rate like? It varies. So cluster headache patients that Nick talked about, and he mentioned the figure 50% response, which is very good. You may not as a patient think that's acceptable or good enough, but comparative to some pharmaceutical agents, it's very good response. In the migraine space, our data suggests about 37 to 45% response rate. And again, that will depend on your own clinical presentation. So if it's related to the menstrual migraine type patient, then you're towards the lower end. Those who suffer with aura, then we find in that group of patients, for some reason, and we don't know, that there is a better response in that cohort of patients. We do have evidence to suggest that chronic patients, so preventative use, you will get a better response to GammaCore than just using it acutely. But yes, it's very easy to access. This form is authorized, signed, returned to us. We send a payment request via PayPal. We have a UK account. If you don't want to use PayPal, you do not have to have a PayPal account to make a payment via PayPal. And then we ship to you via DHL. Shipping is at our cost. And you can have a one-on-one training session with us to make sure you get that placement correct. And it can be left or right. I know I did it on the right. That's just ease of my positioning so you can see the screen. So yeah, we're available. We have follow-up calls available for you. Support is available as needed. my personal email there. I'm happy that people take that. If you've got any questions, if you wanted to share that with your clinician for them to ask, if you want to email us the form back, the address is also on the top of the form. Our website, I know it's a UK, and buying GammaCore on that site is territorial, so you could not buy from Ireland, and that's due to regulatory restrictions on us. But there is a lot of information on there about how GammaCore works, some videos about how to use it, and some testimonials. All the testimonials are genuine, and GammaCore literally can be life-changing for some people. And I am able to offer a €50 discount to all people viewing this webinar for a starter kit purchase before the end of September. Just quote MAI or tell me you watched the webinar with Nick and I process those orders. So I would be doing that for you anyway. Okay, nearly dinner time after questions.
Can I just mention one thing on that, Keely? To Karly, can you hear me?
Yep, go for it.
Yep. So just when you said it, 37% response for episodic migraine. If we look at the clinical trials for all the drugs, you alluded to it with the preventatives, but 37% response is very similar to what people get with the triptans. So things like sumatriptan and the other triptans, when we look in the clinical trials, they've all got about that sort of response. So it's not actually that different from triptans for acute response. And I personally think that it's particularly useful in cluster headache and cluster headache and hemicrania continuum. They're cluster headache, anyone with migraine and cluster headache would rather go back to having just migraine. And I'm not saying using just migraine lightly, because migraine is horrific, but cluster headache is an order of magnitude worse for people suffering both. So the really, really horrific conditions actually respond really, really well, which tells us how genuine this is. I've got no onus to say anything positive or negative, and this is not a promotional talk from my point of view at all. But I use this in my clinical practice. Most of it's in the NHS in the UK. And I think, if I'm right in thinking, that about a quarter of the patients in the UK are actually my patients on GammaCore. So we've got a lot of experience with this. And if you use it for the right things, then I think it can be, as you said, life-changing. So I just wanted to chip that in as a sort of comment, which is not a promotional comment.
Appreciated, Nick, and very valid. And yeah, we undersell ourselves in the migraine space because our data in the cluster space is so good, but you're absolutely right. The migraine data is comparable to pharmaceutical agents. And what I probably also haven't emphasized there is the added benefits of GammaCore and, well, I should say vagus nerve stimulation. So not only does it help in terms of the pain associated with the headache pain, but it also helps. So we have anxiety and depression, CE mark. It can help promote sleep, the brain fog, visual snow people have, lethargy, a lot of other associated things, which if you just Google vagus nerve therapy, vagus nerve stimulation, you will start to learn very quickly about the overall well-being positive effects of stimulation.
So there's quite a lot of data in that where we actually looked at those sort of symptoms in people. We actually designed a trial originally. I helped to design the trial where we looked at not patients with migraine or headache, but patients who presented with dizziness, fatigue, tiredness, mood change, or whatever, certain symptoms rather than a diagnosis to GP land, and they would be given GammaCore. And what it showed, we didn't look at the results as to how much better the patient was. We looked at the healthcare costs for that patient over the next, was it year or 2 years? And actually the healthcare costs became much better for those patients purely because they were better. So a lot of those things were down.